Hello, my name is Diane Hall, CEO of Balanced Senior Nutrition. Our training programs are specific to long-term care. And with over 30 years experience preparing communities for their state and federal surveys, we are able to integrate information from actual ACA surveys into every training module. You'll learn the latest evidence-based research and clinical standards, as well as the rules and regulations you need to stay current and in compliance. We'll focus on teaching you how to personalize the dining experience in accordance with the new dining standards. Enjoy the presentation.
Welcome to Balanced Senior Nutrition's training, an overview of the new dining standards. In this training, you will receive an overview of the dining standards, including their importance to your community, how they were developed, the elements of each, and a brief look at each of the 10 standards. These are not requirements of the Centers of Medicaid and Medicare Services, but those communities adhering to these standards may rely on such adherence in response to questions regarding any changes for more restrictive diet protocols that may have previously been used. So why are the dining standards important? Before we look at their importance in the long-term care communities, let's get personal for just a minute. What time do you normally eat breakfast? What is your favorite snack? How would you feel about having limited choices about the foods you eat and the times that you ate them? Now, to get really personal, do you always eat what you know is really best for you? Do you always follow your doctor's orders? I'm sure that most of us would say that we don't. So, back to the dining standards and why they are important to your community. Let me ask you some questions about your community now. Do you feel regulations become a barrier to offering choices to your residents? Are you tired of documenting weight losses? Are you struggling with rising food costs as you see plates of food being scraped into the garbage? Would the threat of a lawsuit keep you from honoring a resident's choice to refuse a restrictive diet, such as thickened liquids? You are not alone. Feeling your pain and confusion, CMS, the Centers of Medicaid Medicare Services, and the Pioneer Network partnered to coordinate a multidisciplinary panel to use evidence-based research to define standards of practice and require that all facilities begin the change in dining to person-centered care. In an unprecedented move, 12 of the top professional organizations voted to accept these 10 new standards, which will now accelerate the long-term care community's implementation of the standards. This gave birth to the new dining standards in 2011. The goal is to support improved quality of life through individualized care and self-directed living. The pendulum has now swung away from traditional diagnosis-focused treatment to reflect current thinking and evidence-based research. This is the list of the 12 national standard-setting organizations. You can see that it is interdisciplinary, involving nurses, physicians, therapists, and dietitians. These are the 10 dining standards. Number 1, individualized nutrition approaches, that is diet liberalization. Number 2, individualized diabetic or calorie-controlled diet. Number 3, individualized low-sodium diet. Number 4, individualized cardiac diet. Number 5, individualized altered consistency diet. Number 6, individualized tube feeding. Number 7, individualized real food first. Number 8, individualized honoring choices. Number 9, shifting traditional professional control to individualized support of self-directed living. And number 10, new negative outcome. There are 4 elements to each of the standards. First, each standard is based on current thinking and current evidence-based research. Also, for each standard, there is a recommended course of practice and references to back up each of these. The first of these standards addresses diet liberalization. It has been found that therapeutic diets can actually cause weight loss because of poorly tolerated, unpalatable diet restrictions. CMS states a regular diet should be the norm. Restricted diets should be the exception. There is more information at the end of this presentation if you are interested in more in-depth study on liberalized diets. Let's review what we've gone over so far. These statements are either true or false. Therapeutic diets have often been shown to be beneficial as a strategy to prevent weight loss. The standard of practice is to liberalize all diets possible. CMS writes the standards of practice. The second dining standard relates to low-sodium diets. Low-sodium diets are not shown to be effective in the long-term care population of elders for reducing blood pressure or exacerbations of congestive heart failure, and therefore should only be used when the medical need has been documented. An example would be justification for catheter. The third standard deals with a cardiac diet. Low saturated fat or low cholesterol diets have only a modest effect, that's 10%, on reducing blood cholesterol in the long-term care elder population, and therefore should only be used when the medical need has been documented. ADA states there is no evidence to support prescribing diets such as no concentrated sweets for older adults living in healthcare communities. A liberal diabetic diet restriction, NCS, has not been shown to improve glycemic control in nursing home residents. Allow as much freedom as possible. It may be more appropriate to liberalize the treatment goals or targets, that is, the hemoglobin A1C level of 7 to 8, or higher cholesterol levels, rather than add more medications. Medication versus diet should be used to control blood sugar in older adults living in long-term care. Sliding scale insulin should only be used with a new diagnosis or acute conditions where the clinician is attempting to estimate daily dosage of insulin. Glucose monitoring should be done no more than once daily in stable diabetics, more frequently, albeit temporary, if actively adjusting the regimen. Little evidence supports the use of sliding scale insulin as it is reactive in nature and fails to meet the physiologic needs of the person. Standard number 5, altered consistency diet. There is evidence that altered consistency diets may increase the risk of nutrition and hydration deficits. Thickened liquids and pureed foods are often poorly tolerated. Look for alternative strategies. While a modified barium swallow may show that thickened liquids reduce the risk of aspiration acutely, there is little to no long-term evidence that this intervention, that is thickened liquids, prevents aspirations pneumonia. The anticipated outcome of foods ground or pureed and liquids thickened is to improve oral intake and a reduced risk of choking or aspirations. However, data on their effectiveness is inconsistent. There is evidence that improved oral care can reduce the risk of developing aspiration pneumonia in the elderly. Look beyond symptoms to underlying causes to avoid excessive modification of food or liquid. Let's take a minute and review. Are these statements true or false? If a new resident has a diagnosis of diabetes, a diabetic diet that has no concentrated sweets should be ordered. Most incidents of aspirations lead to pneumonia. Current research results are consistent in proving thickened liquids prevent aspiration. Standard number 6, individualized tube feeding. When there is weight loss and functional decline or end-stage disease, the default should not be to place a G-tube for nutrition and hydration. Weight gain from tube feeding has not been shown to correlate with improved clinical outcomes, and tube feeding may not be appropriate for those in advanced disease state. New dining practice standard number 7, individualized real food first. Advocate the use of real food before the addition of dietary supplements. Instead of artificial supplements, extra protein, vitamin, and fiber powders can be added to smoothies, shakes, malts, and other real foods that people like to eat. The dining experience should be as natural as possible, comparable to eating at home. Resident satisfaction with the quality of the food and the dining experience should be a home's priority. Standard number 7, individualized honoring choices. This is really what it's all about. In the end, all decisions default to the person. Is personal choice encouraged in your community? Let's take a moment to review again. The following statements are true or false. When weight loss occurs and all interventions have failed, tube feeding should be the next step to ensure weight gain unless there are advance directives stating wishes against tube feeding. When a resident is at risk of aspirating, tube feeding placement will eliminate risk. All decisions default to the resident. Standard number 8, again about honoring choices. Surveyors will see tray lines or set meal times as a contradiction to choice. Beware if your community is still using these practices. Another red flag will be labeling a resident as non-compliant in a care plan or record. This will be considered a contradiction of choice. Standard number 9, the new negative outcome. All healthcare practitioners and caregiving team members offer choice in every interaction, even with persons with cognitive impairment, in order to ensure control remains with the person. Harm can occur from not honoring choice, which has been proven to bring about earlier mortality. CMS has a deficiency, severity level 4, immediate jeopardy if substantial and ongoing decline in food intake resulting in significant unplanned weight loss due to dietary restrictions or downgraded diet textures provided by the facility against the resident's expressed preferences. Balanced Senior Nutrition also has a training module, Knowing the Important Part of the Regulations, ACA's interpretation. You can find more information at the end of this presentation about our other training programs. The last standard, number 10, shifting traditional professional control to individualized support of self-directed living. A variety and increased number of staff present in the dining room enables both physical and psychosocial needs to be met. Staff can enhance and honor individual choices reflective of preferences. Create a new standard of practice that care plans identify familiar and meaningful foods preferred. When making dining decisions that can be viewed as a risk to the individual's physical health, the plan of care will be adjusted to honor choice and provide the supports available to mitigate the risks based upon the individual's life goals. Put resident choice before regulations and guidelines, such as recommended daily allowances, which are generic, estimated nutritional needs, and non-individualized. Personal choice should supersede medical best practices. Balanced Senior Nutrition has another training, Clearing the Path for Choices Without Liability Risks. More information about this training can also be found at the end of this presentation. Resident dining profiles, that is tray tickets, should be limited to adaptive equipment, allergies, consistency modifications, and unique dietary needs. Preferences should be sought after as choices are offered, not just once and then recorded on a tray ticket indefinitely. These are residents' rights in long-term care, as listed in the Code of Federal Regulations for Long-Term Care. Residents have the same rights as U.S. citizens. They have the right to be informed of health status. They have the right to refuse treatment, the right to make choices about aspects of his or her life that are significant. As far as nutrition, a resident has the right to make informed choice about accepting or declining care and treatment. As stated at the beginning of this training, these 10 new dining practice standards are not required by CMS. On March 1st, 2013, all state survey agencies received this memo from CMS. Please note, however, that these practice standards do not represent CMS requirements. Surveyors should not issue deficiency citations simply because a facility is not following these particular recommended practices. However, facilities that opt to adhere to these practice standards may rely on such adherence in response to questions regarding any changes from more restrictive diet protocols previously used. Our final review questions. Are these statements true or false? Food should be available 24 hours a day. A physician should order real food or fortified foods before ordering dietary supplements when possible. ACA state surveyors are to consider if there is adequate choice provided for the resident if one of 3 conditions are present: set meal times, tray line services, non-compliant used in documenting residents' behavior. The journey of change takes time. Take one small step at a time. You can begin with Balanced Senior Nutrition's new training programs. Liberalized diets, the rest of the story. Clearing the path for choices without liability risks. Knowing the important part of the regulations, ACA's interpretation. Call our toll-free number or visit our website, both listed at the end of this presentation, for further details.
Our mission is to support person-centered dining. Our ever-evolving training modules include food safety, liberalized diets, state and federal regulations, and many more. Balanced Senior Nutrition has worked hard to help our clients achieve a balance between quality of care and quality of life for their residents. Please let us know if there's anything more we can do to help you ensure your regulatory compliance and resident satisfaction.